Your doctor doesn't care if you get better, you're more valuable when you're sick. This isn't a commentary on doctors being bad people. Instead, it's about a bad system. From a business sense and a financial sense, once you're healed, you're a lost customer. We are customers in the US healthcare system where financial incentives are in direct conflict with one another between payers and providers. Payers, or the insurance companies, want to pay as little as possible for services. When they can pay as little as possible for services, they can keep premiums down, they pay less claims, and it improves either profit margins or keeps premiums low to be able to gain more customers. Either way, a win for the insurance company. Providers, from a financial incentive, we're talking doctors and hospitals, want to get paid as much as possible. And to get paid as much as possible, you need to provide high cost, high value services, and a lot of them. Now, the reason we have this financial incentive gap is because most of the care in the United States healthcare system is paid on a fee-for-service basis. That means doctor provides a service, the payer pays for that service. The more services, the more things they have to pay for. You get paid for that 10th follow-up visit, but you don't get paid a bonus for avoiding the 11th visit. Under the system as it is today, we as patients have to rely on the ethics of our doctors to just do the right thing and not allow the business incentives to override what they believe to be the right thing to do. If we have to leave our trust in one of the options, payer or insurance companies or providers, doctors and hospitals, we probably want to leave it with the doctor. But doctors are people. People make mistakes. People have different incentives. People can be taken advantage of. When you have a system where the payer holds all the financial risk, meaning when a doctor charges for a service, the payer just has to pay it, you end up in a situation where payers have to put guardrails on their systems to make sure that they're not paying for something that is unnecessary, unwanted, unwarranted. Because under a fee-for-service model, doctors have no skin in the game, we now have prior authorization. The doctor asks the insurance company if they will authorize payment for something before it happens, basically to say, this is necessary care. The insurance company agrees that it's necessary care, and they'll pay for it, and the doctor will administer that care. A majority of the horror stories you hear in the US healthcare system are around this prior authorization mechanism. Payers feel as though they need to put barriers or guardrails in place because doctors are unchecked when it comes to financial risk. So now we have a prior authorization speed bump that every single patient hates. Not only that, doctors that are reviewing for prior authorization on the insurance company side of things are not typically held to the standard as the doctor providing the care. And so while it's nice to have a second opinion, there's no way to verify that the second opinion is high quality without going out and paying for a high quality third or fourth opinion. Under the prior authorization mechanism, the only way payers have to not pay something is to just deny the claim, and they'll deny for any reason they can find. And so the result we get is a system where there is so much red tape to get through that patient care gets delayed, and when patient care gets delayed, it might exacerbate into something significantly worse. All because payers and providers can't get along because incentives aren't aligned. So how do we align incentives? You might hear the term value-based care. Simply put, value-based care means paying for improved outcomes rather than paying for services. If money is aligned with outcomes, then a doctor gets paid more when a patient becomes healthy. If you're paying based on outcomes, those guardrails become unnecessary. And what that means is we shift the financial burden from a payer to a provider in some way. And one way is accountable care organizations, or ACOs. An ACO is the most idealistic, extreme example of this risk-based, value-based care payment. You'll have one large hospital system or provider system. Think university health systems. A lot of places in the country have a university-based hospital system. I'm in the Pacific Northwest. We have University of Washington Medical Center, and there's clinics all over the area. All of the doctors under this system share one budget. There is one capitated rate for all of the people, and you pay one giant payment to cover all of the care for those individuals. That's like the most simple way of putting it. It's not usually all care included in it, but the idea is that there's this one large pool of money that all of the doctors are providing care under that pool of money. And so the payment is guaranteed, but the care is not guaranteed. The amount of care, amount of services is not guaranteed. It makes a doctor financially responsible if they want to do something that's more expensive. Part of the issue with this model is exactly that. There might be doctors in this system that are just bad actors and or not very good at what they do, and it results in a lot of high-cost care. And a lot of high-cost care eats into the budget. The other thing would be you might potentially turn away high-risk patients because they're going to eat into that ACO budget. And that's not good. Under the current fee-for-service model, You'd be more likely to take that risky patient because they're going to provide more revenue for you as a doctor. Under ACO, it's the exact opposite because the financial burden is now on the other party more than it was before. Doctors are at risk of losing money now, and you have higher profit margins if you take the healthy individuals, provide less services, because you're going to get paid the same amount either way under an ACO. So that's probably the most extreme example of value-based care and shifting the financial risk from the payer to the provider. Another system is bundled payments. A bundled payment is a little more granular than this ACO model of you get one giant pool of money. Instead, you get a smaller pool of money for one episode of care or one procedure and associated aftercare. A good example would be if you're going in for a knee replacement, that bundled payment might be $30,000. And that means the payer is going to pay $30,000 to cover that knee replacement and the associated physical therapy after. It would cover any complications that happen during the surgery. It covers all the physical therapy after. It basically gets you back home. And so in the same way, if something goes wrong during that surgery, or if it becomes overly complicated, or if the doctor makes a mistake and it exceeds that $30,000 budget, the doctor's on the hook for that. But instead of it being overarching care for everybody, it's overarching care for that one thing, for that one person. Bundled payments kind of suffer from a similar thing as ACOs, but to a lesser extent. Doctors might still want to cherry pick the easier procedures to do under the bundled payment and not take the more complicated case. Also, if you're working with like one large practice group or one large provider group, there might be some providers that are under a bundled payment model and some that are on fee for service, and you might just take the ones that you know you can make more money on and shuffle them to the doctors that are under a payment model that makes them more money. And so you really need to make sure that this is holistically done so that you can't game the system. Another downside of bundled payments is they're just not very widely used. Bundled payments are almost primarily used for procedures today because with procedures, there's a pretty set package of services that go with those procedures. You kind of know what you're going to use, what you're going to do, and the budget is pretty consistent across the board. With chronic conditions, take diabetes for an example, there are different types of diabetes. There are different severities of diabetes. There's different medication needs for diabetes. Some people might need a GLP-1 to help manage their diabetes, and some might not. And GLP-1s are very expensive. It's all over the news. GLP-1s are very expensive, both for the member and the payer, and that would eat away at a chronic condition budget like for diabetes. It's not a perfect fix, but it is a more granular way of being able to shift financial risk from the payer to the provider so that the provider has skin in the game, so that the provider is impacted by the decisions that they make financially. Value-based care is talked about so much in the healthcare and health insurance industry that it basically become a buzzword that almost carries a negative connotation now because of how many times systems like this have failed. There's a lot of barriers to moving to a value-based care mechanism like this. The most important thing is when a provider moves from fee-for-service to a value-based care payment arrangement, they're taking on financial risk in some way. That means if they're not performing well, they're going to lose money. And doctors aren't the same as other types of services that you might seek out. We need doctors. Doctors have to be able to help people. Even if they're low performing, we don't want to financially squeeze them out of the market. We would rather help them improve so that they can help patients better. Now, taking on financial risk means you have to have the capital available to be able to bear that risk. And what that means is smaller provider groups or independent provider groups are less likely to be able to take on the financial risk. And so if you're unable to take on the financial risk, you either have to find somebody else to bear that risk for you or stay on the fee-for-service arrangement. In the industry, we see a lot of the large mega hospital and healthcare systems buying up independent practices. And when they buy up those independent practices, you lose kind of that local small doctor's office that you trusted and had built a relationship with to the big conglomerate, just like in any other industry. Independent physicians are able to operate under their practice and make the money that they need to sustain, and they don't have other external pressures that they need to make profit margins for, like the mega systems do. This also disproportionately affects small or rural groups. Rural healthcare providers are already few and far between, and they're definitely not going to have the cash flow to be able to handle a risk-based payment arrangement. Instead, they stay on fee-for-service, the incentives remained misaligned, and payers have stricter requirements for people in rural areas because the payments are only tied to services. And so it furthers the issue of rural healthcare in the United States. I'll say this, fee-for-service is one of the worst ways that we can pay for healthcare because it creates a tug of war between the payer and the provider, and us, the customer and the member, are in between getting pulled both ways. And what it ultimately ends up doing is increasing the cost of care, delaying the time in which you can get care, and there's no incentive to improve outcomes. And so I like to do this, but I'll leave you with another analogy. Imagine you pay a landscaping company to come and fix your backyard. You want to do a new patio. They come in, they provide the quote, you say, yep, let's do it, and they do a whole patio. However, they didn't do it properly and it starts to fall apart within a couple of weeks. You call them up and say, hey, you didn't do a good job and you need to come back out and fix it. And they say, okay. And they send you another quote for the same amount, plus a little bit more to demolish the first one that they built and put in the new one. It would be insane to pay them again for doing a bad job the first time. You would expect them to come back out, fix it for free, and make it right, because that's what they did before. That's value-based care. Value-based care is saying, I got a quote for this much money, you need to make sure that you actually fix me for that much money. But today, they get to charge and charge and charge, and the payers just pay and pay and pay. Prior authorization and denials, while they're happening a lot, it is a very small portion of claims that are happening. Health insurance isn't denying claims as rampantly as you see in the news. It's an issue, but the bigger issue is a misalignment of incentives that resulted in the prior authorizations to begin with. US healthcare does not follow traditional economics. We cannot fix the healthcare system with traditional economics. Providing more services when you're a doctor does not mean that you're providing better healthcare. In fact, at some level, the more services you provide as a doctor probably means you're providing less effective care. We don't have balance. We need to figure out how to tip the scales a little bit so that we can balance payer and provider. If providers have more skin in the game, there's less of a need for payers or insurance companies to regulate how they pay for care. Until we move financial risk to the people holding the decisions responsible for your care, we will always have a broken system. Why would we have the financial risk and power in the hands of somebody that's not making the decisions that make you better? That's insane. And yet, somehow, the system still actually provides care for people. Value-based care can help. We need to figure out a way to make value-based care more accessible for more services so that we can have more effective care for everybody at a lower cost. Drop a like. Let me know in the comments what you think about value-based care. If you're an expert in the industry, I'd love to hear your thoughts. I know a lot of people have thoughts on this stuff, and this was very much scratching the surface. Thanks, guys. See you next time.